Hello and welcome to Nitty Gritty Nursing with Nurse M. Today I'm going to break down and talk about blood transfusions and the different types of blood transfusion reactions that you might see or that you might have to learn about while you're in nursing school. But just some fun kind of historical facts about blood transfusions. The first human-to-human blood transfusion was actually performed in 1818. And the first hospital blood bank was actually established in the 1940s. And for the longest time, we used this clinician trigger rule that was a 10-30 rule. So 10 being the hemoglobin, if it fell below 10 grams per deciliter, or hematocrit below 30, right? Usually you had to be below 10 and below 30. It would precipitate the requirement for a blood transfusion to be given to a patient in hospital. Now, that particular rule lasted for more than 30 years, despite lack of research, and now we don't follow that rule. But when I was growing up, it was in nursing world, it was always, well, what's the hemoglobin and hematocrit? And if it was below 10 and 30, there was consideration for blood transfusion to be given. Now, there's a lot of risk to the blood transfusions because as patients get more blood transfusions, they have the potential to develop more antibodies that can then predispose them to blood transfusion reactions down the road. Now, in today's society, on average, about 5 million people in the United States are going to receive a blood transfusion every year. That means that they'll go through about, 14 million units annually for these 5 million people. And then requirement and the need is about 38,000 units of blood every day that hospitals or clinics or infusion clinics are going through in the US. And there's a lot of different components when we talk about blood products, right? You've got your red blood cells, you've got your platelets, you've got your fresh frozen plasma, and then there's cryoprecipitates. I will break down some of those as we kind of go through it, but to really talk about who ends up getting blood, and it has to do with people that don't have it. So either they are some sort of car crash or trauma victim who actually loses blood. So the red stuff is on the outside of the body when it should be on the inside of the body, and we can't salvage it like we would be able to in surgical suites, for example, if they can control the amount of blood loss and then retransfuse that person their own blood. Or maybe they've got some sort of infection or liver disease, for example, that stops the body from helping to properly make adequate blood. Or they've got some sort of illness that's causing a persistent anemia, like kidney disease or some sort of cancer or thalassemia or aplastic anemia, something like that. Or they have some sort of bleeding disorder. And that's where you're going to have your hemophilias or your thrombocytopenias, where there's not enough platelets, so then they just bleed and bleed and bleed. So ultimately, the people that end up getting the blood transfusions have something wrong with the blood. Either they're not making it, it's not inside them, or there's a problem with it to begin with. And when we go to do a blood transfusion, there's a few different considerations that we need to keep in mind. So in the hospital and the clinical setting, in order to get a blood transfusion, we use a large bore IV catheter, which means, right, it comes in 24, 22, 20, and 18 gauge, even 16 gauge IVs. The smaller the gauge, the larger the bore. Classically, in most hospital systems, you're going to see patients with either a 20 gauge, maybe a 22, or maybe an 18 in your adult population. In your pediatric population, we are probably closer on the end of the spectrum of 24 gauge, 22 gauge. The reason why the larger the gauge, the better, is because as we are transfusion, especially red blood cells, and they're going through that catheter, we want to make sure that the lumen size of the IV is big enough so as not to do damage to the red blood cells that we are putting into the person. If you give an adult, for an example, a unit of blood through a 24 gauge catheter, we have a really high likelihood of the blood cells, the little red blood cells, being destroyed before they even get inside the person. The other big thing is that when we give a blood transfusion, we use a specialized Y tubing set. And the reason why we do that is because it's actually got this special filter that drops into it. So you will prime this tubing only with normal saline. Anytime you go to do a blood transfusion, you only give it with normal saline because it is isotonic, which makes the cells happy and it doesn't destroy them or shrivel them up. So you use normal saline in this special Y Y-site tubing, and it's got basically 2 access points at the top that kind of merge into a filter, and then the rest of the tubing that would connect to your patient. The reason why we use this is because you will prime the tubing first with normal saline, and then you will clamp the normal saline off up top and then hang your blood product on the other side and let that flow freely. Now, classically, blood products, and I'm going to break down each of the different variants of blood products that you might be seeing, there is an allotted time period that you have to give these units of blood because they are perishable, if you will. It's a living product. And so we will walk through, classically, it's about 2 to 4 hours is your maximum. So for a unit of packed red blood cells, your maximum amount of time, especially like on your board exams, is going to be to infuse this in at least 4 hours, which means if you understand the general volume of a packed red blood cell unit, which roughly hangs out around 300 milliliters. It could be plus or minus 50 milliliters. I've seen 285 milliliters. I've seen 312 milliliters in a unit of blood. And really what that has to do with is whoever was donating the unit, that's just basically what they took out with the plasma, with everything else that was inside of it. So when I was learning in my young nursing years, I always knew that if my unit of blood was roughly 300 milliliters and I had a maximum time period of 4 hours to give it, my minimum, start time was going to be on a pump 75 milliliters per hour in order to get through all of that volume in 4 hours. And then the other big thing with blood transfusions is we're really big on doing vital signs, and your facility will have a policy. It's going to be, though, if not more stringent, it's going to be you must take a full set of vital signs. This includes a temperature before you even start the blood product. And then you are supposed to hang out with the patient at the bedside for the first 15 minutes while they are getting the blood transfusion to make sure that they don't have a reaction. And then they get another set of vital signs done 15 minutes into the transfusion. Now, that is classically what most policies will say. And again, I'm not going to speak for every hospital. So depending on where you are, pull your blood transfusion policy and read what it says. It should boil down to even what size IV catheter you should be using and how fast it should be going in. I personally, when I'm giving someone a blood transfusion who's never had a blood transfusion before, I'm in the room with them for the first 15 minutes, absolutely. I do the set of vital signs before I even start it. And then I'm a little bit overzealous and I will throw another 1 or 2 vital signs in the middle of that 15 minutes, especially if I'm concerned about something happening. Again, full set of vital signs: blood pressure, heart rate, O2, respiratory rate, temperature, pain level. You're looking at all of those things. So let's talk about the different types of blood products. The big one that we all associate with a blood transfusion is packed red blood cells, and you'll see it abbreviated as PRBCs. And packed red blood cells are blood product that's used to replace the erythrocytes or the actual red blood cell inside of individuals. The infusion time for one unit is usually between 2 to 4 hours. Again, it's going to depend on how much fluid volume is in there, but your max cap is 4 hours. Now, from a laboratory perspective, each unit should increase the hemoglobin of someone by about 1 gram per deciliter. And if you reflect back to that super old school rule that I grew up with when I first started nursing of the 10 to 30, I knew that if my hemoglobin was below 10, we would be infusing someone with blood products. That is now no longer the case. You will come across patients that are maybe 6, 7, 8, 9, and they're not going to be in the queue for a blood transfusion because we now understand the risks versus benefits. But if you, from a larger perspective, look at it, each unit of packed red blood cells should increase the hemoglobin by about 1, and it should increase the hematocrit by about 3%. And that particular lab value is going to take about 4 to 6 hours after the infusion is done for you to see it come across on that patient's next lab draw. And realistically, if we're giving packed red blood cells, we're basically evaluating whether or not it's effective based on how that person feels. Because they were anemic, they didn't have enough erythrocytes to transport oxygen and do everything that we needed it to. So did their symptoms improve? Did their hemoglobin and hematocrit improved as well. These are all things that we would want to consider when we're giving a packed red blood cell product. Now, another component of blood products that we'll give are platelets. And platelets are used to treat thrombocytopenia and platelet dysfunctions. Serves logically, you're going to give platelets if people don't have platelets. What we found, though, is that clients who get multiple units of platelets multiple times, right? So if they come in and they get 3 or 4 units of platelets, they can become alloimmunized to different platelet antigens. This is because every time you get a platelet donation from the blood bank, effectively, you're actually getting a platelet donation from a different donor. So they are getting more exposure to the platelet antigens that are out there. And so realistically, like the clients that need platelet transfusions may actually benefit from receiving only platelets that match their specific human leukocyte antigen. So it requires a little bit of additional testing. Now, because it is just platelets, cross-matching is not required. However, it is usually done because platelet concentrates can actually contain a few red blood cells. So packed red blood cells have to be cross-matched because you can't give, someone who is B positive blood, A blood. It just doesn't work. They will have a severe blood transfusion reaction. Platelets, not required to be cross-matched. However, they are because we know that the more units of platelets that someone gets, the more alloimmunized that they can become. Now, the volume in a unit of platelets is going to vary. So you always, when you're giving blood products, one of the things that we have to keep track of is intake output. You want to make sure you really know how much fluid volume you are giving these patients. So you always want to check the bag for the volume of the blood product in the milliliters and make sure you're documenting that in the record. Now, platelets are given immediately upon receipt from the blood bank. And the reason why is because you have to give it quite quickly. Now, platelets are alive, right? They are an active component. So as soon as you get the platelet unit from the blood bank, you should be immediately giving it. And this will infuse over 15 to 30 minutes. Unlike the packed red blood cell counterpart, which can take up to 2 to 4 hours. Platelets, just give it right away. Because when we go to evaluate whether or not the platelets have worked, we're going to look at it based on the platelet count of the individual. And usually the platelet count will redraw the platelet levels an hour after the infusion, and then again 18 to 24 hours after the infusion, because for each unit of platelets we would expect to see anywhere between 5,000 to 10,000 increase in the platelet lab values. Now, a third component of blood products that we'll give is fresh frozen plasma. And fresh frozen plasma may be used to provide clotting factors or just volume expansion to individuals that need it. It has no platelets. So fresh frozen plasma has no platelets. It's just what we're giving to increase volume and or to provide clotting factors. And we infuse the fresh frozen plasma within 2 hours of thawing. So while the clotting factors are still viable, we want to infuse it, and we infuse it over 15 to 30 minutes. Now, with fresh frozen plasma, RH compatibility and ABO compatibility are required for the transfusion of plasma products. So you have to do that type and screen with the RH and the ABO in order to give the fresh frozen plasma. We know that it's been effective in our evaluation when we look at coagulation studies of these patients, specifically prothrombin time and partial thromboplastin time. And we would expect to see a resolution of any hypovolemia that they had if we were giving it as that volume expander. Now, the fourth blood product that I'm going to talk about is the cryoprecipitate, which is actually prepared from fresh frozen plasma, but the cryoprecipitates can be stored for up to 1 year. And once we thaw these down, they have to be used. You can't just de-thaw it and then say, oops, let me re-thaw it, didn't want to use it. So it doesn't work that way. Once that product has been thawed, it must be used. And 1 unit of the cryoprecipitates we would give over about 15 to 30 minutes. And we use cryoprecipitates. Oh my goodness, that word gets a little bit jungly. So we use that to replace clotting factors, specifically factor VIII and fibrinogen. So we know that when on our evaluation, if we've got a patient who's been receiving cryoprecipitates, we would look to see if they have improved by their coagulation studies in their lab work and their fibrinogen levels. So those are the 4 big types of blood products that I'm going to discuss: packed red blood cells, platelets, fresh frozen plasma, and the cryoprecipitates. Now, in terms of types of blood donation, we've got an autologous, which is a donation of someone's own blood before a scheduled procedure. So let's say I wanted to go in and have a surgery done, and I only wanted my own blood. I could, on a schedule, donate my own blood to have it on standby in the event that I needed it during the surgery if there was going to be expected blood loss. The benefit to this is that it reduces the potential risk of disease transmission and transfusion complications because it's my own blood. Now, the autologous donation is not an option for anyone who has leukemia or bacteremia. They don't get to do that. And technically, someone can make a donation every 3 days as long as their hemoglobin remains within a safe range. And when they are doing this in the anticipation of some sort of surgical procedure that would require blood product, those donations would then begin within 5 weeks of that transfusion date, and it ends at least 3 days before the transfusion. So if someone decides that they want to donate their own blood for themselves for some procedure, they can do that, starting 5 weeks before the procedure, and they have to stop 3 days before the procedure, and they can donate every 3 days so long as their hemoglobin remains safe. So for an autologous donation, these people have to be fairly healthy and be able to do this. The other type of blood donation is going to be a donor donation, which is what you think about the American Red Cross and what they do. Those are donor donations, and we call those allogenic blood donations. And it's from someone else other than the recipient. And then a third option is a direct donation blood, which is blood from a donor other than the recipient. However, the donor is known, or they know the identity of the recipient. And technically it's often a family member who has been typed and screened, a family member or friend, and has the exact same blood type as the other individual. So those are the 3 big ones. Either it's autologous, where the person is donating their own blood for their own procedure. It's allogenic, where they're going to receive blood product from the donations of individuals, like through the American Red Cross, for example, or there's a direct donation where someone who knows the recipient, either a friend or a family member who has the appropriate blood type, would be able to donate their blood for them in the event that they needed it. Now, going through that blood transfusion process, I mentioned the IV gauge that you really need. Bigger is better because it increases the flow rate and prevents the red blood cells from being damaged. There is also going to be that Y-site tubing with the normal saline that you would prime it with. And then a consent is an absolute requirement. You cannot just give someone blood if they do not want it. And there are religious practices out there that do not want blood products, and we need to respect those and honor those in their wishes when they're seeking health care. So the only time that a consent is not technically required is usually during some sort of emergency where the person is unconscious, and we work under the presumption that everyone wants to be saved. So there are those things. So get the consent before you do anything in terms of blood. And often in many facilities, the consent specifically for blood transfusions is a separate consent from like a procedural consent. There might be a tiny box on a procedural or surgical consent that says blood products. You would just have to look at the consent form that your particular facility is using at any given time. This brings us ultimately to the types of reactions that can occur when someone is getting blood transfusion, and what are you going to do? So adverse reactions are going to vary, but some of the most common side effects that patients will get when they are receiving a blood transfusion or a blood product transfusion are going to be things like chills. They're going to spike a temperature. They might become dyspneic or short of breath. You'll see changes in their blood pressure. They might get nausea. They might have sudden pain, especially in their, flank area. They might have a rash. They might get hematuria. And then there is also the potential for graft versus host disease. You will see that abbreviated as GVHD. And this is typically seen in immunocompromised patients. Those, like, for example, patients who've had cancer, who've had radiation, and the radiation depletes or inactivates their white blood cells within their system. So by giving them red blood cells that are unradiated, those white blood cells then attack, right? Takes about a month or two, but it's commonly seen in bone marrow transplants. It's super rare in blood transfusions, but that does exist, so I put that out into the universe. There are two basically pathways for an adverse reaction if it's going to occur during a blood transfusion. You've got your non-immunologic reactions, which is going to be specifically about circulatory overload, or you've got your immunologic reactions, meaning the person's immune system is going to react somehow. Now, your non-immunologic reaction is going to be what we call TACO. It's a transfusion-associated circulatory overload reaction, and it is what it says. So when we think about a transfusion that we're giving circulatory overload, it is caused by the infusion of blood at a rate too rapid for a patient to tolerate. This is going to be in your potentially like your elderly population that has congestive heart failure, or anyone with a heart that cannot tolerate the infusion or the rapid infusion of a massive amount of fluid volume. And as a result, they become overloaded in their circulation system. And what do they look like? Well, they will develop a cough. They're going to have dyspnea. They might have some chest pain and wheezing. And on that auscultation, you're going to hear those changes in breath sounds. They're going to have hypertension, too much fluid volume. And because they've got too much fluid volume and they've got this circulatory overload, they then might have tachycardia or distended neck veins because it's a fluid volume issue. So if they're getting the infusion and you start to see this, the big thing we would do is slow that rate of infusion, put these people in an upright position, notify the provider, and then give them oxygen. We will then probably give them diuretics. We're going to watch for dysrhythmias, and we're going to go from in that way. Now, that's the non-immunologic reaction column. In the immunologic reaction column, there's a few different things that can occur. One of the big ones is a febrile non-hemolytic reaction. And that's the most common complication that people are often going to see. And it's an immune response to the cytokines or the white blood cells in the stored blood that they're getting. Now, normally what we'd see is these individuals have a temperature increase of 1 degree Celsius or 2 degrees Fahrenheit, depending on what you're operating off of, or more, and they will develop chills and mild dyspnea. This is frequently seen in patients who've had multiple transfusions or pregnancies that increase their likelihood of having this febrile non-hemolytic reaction. So basically, the reaction is fairly benign. However, if they have that reaction, you would still want to stop the transfusion and then assess your patient for their airway, their breathing, their circulation. If you're stopping a blood transfusion or a blood product transfusion because you suspect some sort of blood transfusion reaction, kind of the general rule of thumb is you save all the tubing, all the bags used, and you return everything back to the blood bank for analysis. So you've got that febrile non-hemolytic reaction, meaning they are going to spike a fever because of that response to the cytokines and the white blood cells that they've got stored in there. Now, that's the febrile non-hemolytic reaction. And then you can have an acute hemolytic transfusion reaction. And these are an emergency that result in the destruction of the donor's red blood cells due to some sort of incompatibility of an antigen. And what that basically means is something happened or went wrong where they're getting there's an ABO incompatibility. So the person with the B-type blood is getting A-type blood, and either it was mislabeled, the typing screen wasn't done correctly somewhere, it got missed, and basically what happens is the blood starts to react to each other. And that starts to essentially lead to hemolysis. It results in this rapid intravascular hemolysis, leading to disseminated intravascular coagulation, where it's that clotting and bleeding problem and shock, and then ultimately like an acute renal failure. And because of this, what you're also likely to see is they will have chills and diaphoresis and muscle aches and back pain. They're going to have that rapid, thready pulse. They might be dyspneic. They're likely to have some sort of nausea, vomiting, or abdominal cramping. And so you want to stop the transfusion, continue with normal saline, and then notify the provider and send everything back to the blood bank. Now, your third type of immunologic reaction that you might see is called a TRALI, and we say TRALI for transfusion-related acute lung injury. And this is fairly similar to an acute respiratory distress syndrome that someone might have, because there's an inflammatory response that results in direct lung injury, causing this massive permeability. And so fluids and proteins then basically flood into the alveolar space, and it compromises oxygen transport. Now, these patients, if they're going to have a TRALI reaction, they're going to be dyspneic immediately and tachypnic. So they'll be really short of breath, and they're going to be breathing really, really fast, and they're going to have hypotension and a fever. 15% of these patients ultimately are going to require mechanical ventilation because of the direct lung injury that is occurring. So because of that massive microvascular permeability and the leakage of the fluid, it's a big problem that we need to sort of make sure doesn't occur. Now, the interventions for these types of reactions that you might see are going to be to stop the transfusion, change out that IV tubing down to the IV site, and keep running normal saline. So you want to stop all of the blood product, just put normal saline up and running, but like that tubing that had the blood product in it, that's got to go. Tell the primary care provider that this is happening and tell the blood bank, and then you're going to stay with your patient and basically keep an eye on them, doing their vital signs every 5 minutes and preparing for any sort of emergency that might happen, or give them emergency medications that the provider might order, and return everything back to blood bank, attach labels, the transfusion record, and then you're going to document everything that happened and kind of go from there. So when you're thinking about potentially giving someone a blood transfusion or some sort of blood product infusion, and you are wondering whether or not they need to be type-in screened, really the only one that maybe doesn't is a platelet, but most of the time we do a type-in screen. In emergencies, what you'll see is that the universal donor, which is O negative, is what will be given in the event that there is not the luxury of time to do an appropriate ABO type and cross-match. So in that ABO type and cross-match, what you will also find is that we're looking at not only the Rh factor, which refers to the immunologic D antigen, right? So someone who's Rh positive has the D antigen, and someone who's Rh negative does not have the D antigen. But we're also looking at antigens, which are surface markers on the red blood cells specific to the type of blood that person has. And so if an antigen that is not found on the body's own cells is found, it will launch an attack against that antigen, which is why we want to do this type-in screen. Now, the more blood products someone receives in their lifetime, the higher likelihood they're going to develop antigens that are really hard to try to match. So that's why that threshold or that clinical trigger of 1030 rule has kind of gone out the window. And really, we're actually, which we should have been doing all along, evaluating what the patient looks like and how they're tolerating it. So that's everything that I have on blood transfusions and blood reactions. In terms of the reactions that you're likely to see, you'll see that immunologic reaction, which is going to be those febrile non-hemolytic reaction where they're going to spike a fever, that acute hemolytic reaction where the red blood cells just start shredding on the inside, and that's really, really bad, or the transfusion-related acute lung injury, TRALI, which is basically a variation of ARDS that's occurring, and many of those patients end up on mechanical ventilation. Or you're going to see that non-immunologic reaction, which is the TACO, transfusion-associated circulatory overload, and just think about what those patients look like when they are on a circulatory overload. So if you have any questions, feel free to reach out to the email listed in the podcast description. If you like what you've heard today, make sure you like it in the platform that you're listening to it in. Otherwise, go forth and keep on learning.